Good afternoon, everyone. Welcome to our latest SANDATA webinar. The future is here, strategies for success in value-based payments. My name is Phil Feldman. I am National Director of Revenue Cycle Management at SANDATA Technologies. And my background is I've been in home care for 23 years with various types of providers in various capacities. The agencies I've been with in terms of the type, I've been with skilled adult and pediatric agencies, home infusion, custodial care. My roles have been financial and operations, and a mix of the two. Currently at SANDATA Technologies, I am involved with the SANDATA Revenue Cycle Management outsourced service offering, and we'll talk a little bit more about that later in terms of what it is, because I'm really excited to be talking about value-based payments today. It's been a big interest of mine for a very long time, really mainly because finally this is an opportunity to acknowledge and validate the value of home care and IDD services. So let's get into it. The agenda for today, certainly what are value-based payments? How were they derived? How are they administered? Where did they come from? Preparation for value-based payments. How can you prepare your provider agency for value-based payments, both internally within the agency and externally across the greater health community, which really includes payers as well as other providers and provider types? What are the roles of the agency departments in terms of compiling data, analyzing that data, publishing it both internally and externally? And we're also going to talk about what departments are going to be involved, which is really clinical, operations, financial, and revenue cycle. So what's the genesis of all this? Well, historically, providers were paid on units of service, and we still are to this day. So it could be hours, or a portion of hours, or it could be a visit, and that yields, a unit of service yields a unit of payment. But it is widely felt that there really is not enough attention being paid to really the outcomes that clients are experiencing. How do they fare? How do they do? And that is not just for home care. That's really for hospital providers. It's for any provider in the healthcare continuum. What's the outcome? So the delivery model is moving towards value-based. What are the outcomes in our client or patient population? And we're going to be paid based on that. Really, the intent is to improve consumer outcomes, both at the individual consumer, but across the entire population, kind of from the bottom up. So, as a rising tide rises all ships, and that's what's happening here. So they're looking to improve the health of the entire population, and ultimately through that to reduce cost. So the model most often used is a reward to healthcare providers for meeting certain standards, which are indicative of the quality of the care that their clients or patients receive. And it's really part of a larger strategy, ultimately, to reform how healthcare is delivered, how it gets paid for. So where is this all coming from? It's really coming from CMS is really driving this. So, first of all, they want to see that the healthcare system takes accountability for quality and the total cost of care. They want to be able to measure and ensure that everyone is enjoying better outcomes and overall health improvement. They want to increase patient involvement. So patients aren't just going to be just blindly receiving care. They're going to be actively engaged in the care that they receive, in the lifestyle changes that occur. It's going to be an increase in individualized care, and we want to get their input. And then it's no longer one size fits all in terms of the care that's provided. It's individualized to the patient, ultimately steering the entire continuum. And better outcomes, what they're hoping is that affordability will be brought to bear, because better outcomes ultimately takes the cost out of the healthcare continuum. So if you're reducing hospitalizations, you're reducing other high cost care by improving ongoing day-to-day patient and client health, and keeping people at home, that ultimately takes a lot of cost out of the system. And then ultimately collaboration. So providers, providers of multiple types, all working together towards the greater good of the healthcare consumer population. So CMS is pushing the responsibility down to the states. That's really who is administering all this at this point. And it really relates to two things. It relates to quality and really improving the quality of life. It's a broader definition of care. It's really more about overall health of the consumers versus just that individual particular episode of care. And then network adequacy, they're looking at it from two perspectives. Certainly, not just looking at it from the standpoint of, how many providers do you have who can support long-term services and support consumers. But to me, what it all means is having providers who take a more holistic approach and not just showing up. And actually, if you look also at the last part of that sentence, it's looking towards time and distance and not just compliance. So visually, what does this look like? Really, what it is, the bottom line is, instead of getting paid for activity and units and quantity and volume and just showing up, we're getting paid now for providing better quality, improved outcomes, and overall better value. And this creates a financial opportunity. And this is something that it's enabling us, or will enable us, to do what we always wanted to do. So I know on a day-to-day basis, we're always looking for ways to improve the outcome of our clients. And that might be making an investment in an extra nursing visit, an extra assessment of the clients to supervise the caregiver, with inserting a little bit more nursing cost into the case. Maybe the caregiver needs to stay a little longer. Maybe we need to invest in better technology. Well, in the current world, in the pre-value-based payments world, that was always an extra cost and didn't improve our revenue. So we typically were not reimbursed for that. But in the value-based world, because that contributes to the quality of the care that we're providing, which in turn contributes to better outcomes for our consumer and client and patient population, there's an opportunity there to improve our margins, improve our profitability, and therefore that additional cost that we're inserting into the care that we provide really becomes an investment as opposed to a cost. Is it really happening? Yeah, I know it's taking a long time for us to really get there, but for a long time now, larger agencies have been engaging with projects with payers to address care gaps. And these are national and regional providers. If you were to look at, just go into the Home Healthcare News website and search value-based care, you'll see articles in there where large national providers are talking about how value-based contracts, value-based services, payer projects, et cetera, are becoming a larger part of their operational profile. So they're stepping into it and taking big steps into it. A number of states already have roadmaps to value-based care. New York in particular is really already there. Long-term service providers and all types of providers actually have value-based care components in their contracts with the state and with the MCOs. Bonuses are already starting to be paid. The measurement process has begun. Pennsylvania is starting to put out commentary on value-based care and what their mission is and where they're going with it. So you're starting to see it more and more. Sandata definitely is keeping an eye on this. We're watching for developments. Some payers are already speaking with us about capturing social determinants of health and outcomes tracking at the point of care. Our software, to a certain extent, already supports this. And we're going to continue to adjust and monitor this so that we can support our customers and the provider community on being prepared for value-based care. What are some examples in terms of some of the metrics? Now, this comes out of New York, the New York model, which is very far advanced. And you'll see, if you look at this, it's really all about cause and effect. It's not really all that complicated. Percentage of members who didn't have falls resulting in an injury, people who got a flu shot, avoiding potentially avoidable hospitalizations for very specific disease states that we can provide some influence over. People who just remain stable and in terms of pain, NFLOC scores, urinary incontinence, who either people just remaining stable or improving, shortness of breath, didn't experience uncontrolled pain. And here's where some of the more holistic aspects come in terms of people being lonely and not distressed. And as you can see here, getting engagement from the clients in terms of, hey, my quality has been good. I am involved in making decisions about my plan of care. And you know what? My aide's doing a good job. So these are observations that are actually coming in and being measured for specific agencies in relation to the overall population. And that's starting to be used to drive bonuses in New York. In the IDD world, and I know we have on this call a lot of IDD providers in attendance, and in that situation, cause and effect on outcomes is kind of more difficult to measure. So it's still being piloted. It's in its early stages. What they're talking about is taking a look at some specific metrics like staffing levels, reduction in waiting lists for admission, how quickly they can consumers can become serviced. And again, going back to client engagement, individual experience data reporting on their level of self-determination. So how do we prepare? At a high level, it's certainly, we want to be prepared to effect better quality. And in that case, if you can't measure it, you can't manage it. So measuring falls, hospitalizations, other adverse episodes, and the underlying data behind that. Putting into place programs based on that data, preventing these adverse events in the first place, enhancing client and consumer satisfaction with the services that we're providing. And then building relationships and exchanging data are really related to each other. This is both with other provider types, other providers, and with payers. So most frequently, it's going to be with MCOs who are really driving this process, and with Medicaid, but it could be other types of value-based payment contractors, accountable care organizations, independent physician associations. And this is the exciting part, because these groups of providers are realizing that home care and IDD services support the people that they're responsible for, that they are treating. And then we are the long-term hands-on providers for this population. So they're going to be looking to our industries as facilitators of their own value-based requirements. And then there are regional health information organizations, which are just basically big data repositories that reside at the state level, and they collect data from a variety of providers and they share it with subscribers. So you can obtain data at the individual client level, you can obtain data at the broader population level to help you drive your policies, procedures, protocols. How do we prepare internally? How do we accomplish all that? Certainly, we need a well-trained staff. So the clinical staff, there needs to be protocols and standards put together to provide effective care, to create effective care plans relevant to the client individually, and ensure that they're followed. On the ops side, we need to ensure that we have capacity. We have to hire aides and caregivers that meet our standards. And we have to be able to capture on the intake side diagnoses, and then on the ongoing coordination side, communicate feedback from caregivers at the front line within our organization, particularly to the clinicians. And then our field staff, certainly training them on what issues to watch out for, what to report back, ensure that they follow the care plans, ensure that there is aggressive follow-up when these things don't occur. How do we measure it? What are some things that we measure? Certainly care plan compliance. So we have facility, we have care plans in our system. So we're looking for care plans that didn't go in. Are there missing care plans? Are caregivers flying blind because there is no care plan in place? We have to be able to ensure that our caregivers are entering tasks, that they're performing those tasks, following up with them when they're logging out of a visit and there's missing information. The caregiver observations are enormously important. So they're the eyes and ears in the home and in the facilities for IDD clients. So gait, symptom changes, any safety concerns, fall risks, loose wires, loose carpet, etc. Clients a little wobbly. Then of course, are they compliant with their meds, with their diet? Does it look like they're taking their meds? Are there bottles of meds out there that don't appear to be, getting emptied? Looking in the refrigerator, is there food in there? Does it appear to be the right kind of food that fits their diet? Is it old? Does it look like it's moving? And then looking at our adverse events. So looking for trends, looking at hospitalizations, looking at falls, and then developing corrective action plans around those observations. So that's the big key, is really taking action. And then also, because we're making these efforts, report them to the MCOs, report them to the client's physician, report them to the family, etc. So from the field staff perspective, they're collecting a lot of this non-clinical data. Just asking the clients, are you taking your medications? Are you eating regularly? Are you hydrating? Have you had any falls? Are you gaining weight? Are you losing weight? This is very valuable data. It's simple questions that the caregivers should be asking. And really, in terms of this group of people that I know that are on this call, it's really a rhetorical question in terms of what's the value, because we all well understand what that value is, and we're doing it today. Our operations staff certainly should be concerned with service quality. So they should be looking at unconfirmed hours. Is that just unreported time, or is it an actual missed visit? Are there cancellations? Why? We should be looking to make that up. Running reports from the agency management system about underserved clients. Some examples: authorized but not scheduled cases, missed shifts, short-served shifts, late shift starts, things like that are all valuable data that's giving us a heads up into quality. Looking at call-outs, substitutions, schedule changes, client complaints. I remember in my day of running an agency, our branch directors and our DONs always reviewed and followed up on every client complaint. So is it a client issue? Is it a caregiver issue? And there needs to be feedback within the operations. So, the coordinators talking to HR or intake to just expand on issues that are going on so adjustments can be made to those operational aspects. Certainly feedback to the clinical side on all of this. So another opportunity really is the care gaps. What is a care gap? A care gap is something that's not happening in terms of a client's well-being. So, and we have an opportunity to close those just by gathering data. So, questioning clients, questioning the family. Has the client had a mammogram? Have they had prostate screening? When was the last time they saw their physician? Have they had all of their immunizations? And so there are some examples of how this works in terms of closing these care gaps. So, there was a project that occurred where looking for a provider working with MCOs, looking for anybody who hasn't seen a physician in over a year. So the provider, made the inquiries, reported back to the MCO, encouraged them to book an MD appointment, and the result was a 98% closure of this very important gap. In terms of falls prevention, there is a provider who invested in a PT. The PT made client visits who the caregivers or the nurses identified as a fall risk, and then they addressed the risk. Is it a client issue? Is it vertigo, the balance, initiate exercises for that? Is it is it a home environmental issue? Were there fall risk drivers such as loose carpets, loose wires, clutter, things of that nature? And then they published the results with the payer, and it was enormously successful. So this is an opportunity for not a lot of effort above and beyond what we normally do to make a very big impact on quality and on the outcomes. Potentially avoidable hospitalizations is a big factor that's being measured in a number of states. New York mentions it very specifically. So these are hospitalizations that are due to very specific disease states, like heart failure, respiratory infection, UTI, sepsis, anemia, electrolyte imbalances, things of that nature. So it's a matter really of studying your population, looking at hospitalization rates, why did they go into the hospital, and then developing care protocols standardized to address that, and training nurses, frontline staff, and coordinators who are getting the observations back and then holding them accountable for sharing that information and taking action. Continue to monitor the data, adjust your care plans, and then celebrate your success, because this will lead to success. So data collection is really the all-important thing and activity here. Excuse me. So understanding your resources, knowing what your resources have, who in your organization can collect this data in terms of getting it into the system and in terms of analyzing it. And it has to be consistent, and it really has to become a part of the operational process. So caregivers need to be getting it into their apps in the home and their devices in the home, and then people need to be looking at it as part of the normal organizational workflow. And how does that work? So you're capturing data in the home. It's being shared both internally and externally. It's being reacted to. Interventions are being developed. And that in terms of those measurements create value, and they support you getting paid. They'll support you getting your bonuses in the value-based payments world. And that happens when you report on it to the MCOs. What facilitates this to a great extent is really electronic visit verification. So it's not just about compliance, it's really about supporting the quality of care that's provided by being the facilitator to collect this data. What's the cycle? How does that work? Certainly the payer who has access to diagnosis codes and clinical information on their member is authorizing a certain level of care. They're using the acuity and the disease states of the member to advise the provider what needs to be provided. The provider then schedules those services, they staff the case, they assign the tasks, excuse me, and then they collect the metrics. And then EVV facilitates that by certainly confirming that the caregiver showed up and that the client is being addressed, that tasks are being performed, and those non-clinical questions are being asked and answered. That all feeds the agency management system, which then drives reports and somebody looking at this data, excuse me, and intervening and escalating and reporting, and the cycle goes all back to the payer. So how does EVV help this? Certainly, driving the reduction of lost hours. Lost hours create risk, but also lost revenue. So it helps fund this by maximizing your revenue. Authorization utilization, tracking unused units, minimizing denials for non-compliance. Again, it's about risk and revenue. Communication with the field staff, it creates efficiency and effectiveness. So certainly getting directions to the caregivers, pushing out new cases, changes in schedule, and then grabbing the data in from the field. So the metrics that the caregivers collect are used internally, excuse me, and then filling difficult cases. So EVV is a differentiator. Certainly, as I said, it's data beyond check-in and check-out. It's not just about compliance that the visit is being performed. The data itself creates value, and that leads to a differentiator for you as a provider in the provider community. It allows you to leverage the value because the data is real-time. You're collecting early warning signs, and it's establishing the relationship between the caregiver and the member because it's documenting their interaction. Managed care absolutely looks for this. And you can, it also allows you to react to what you're seeing from a management and clinical perspective, so you can initiate the right interventions. In terms of how does EVV support coordination of care, certainly improving the scheduling, immediate notification of missed visits, appointment changes. You can communicate directly with a clinician or a caregiver's device. Offers of new assignments can be sent out automatically. The monitoring is near real time. And you get to intervene and resolve issues immediately. Plus, all this data is being fed into the system, which then gets printed out and produced in reports that can be evaluated, analyzed, reacted to. The SAN data system absolutely supports value-based care. And operating the agency in the value-based environment. So in terms of staff scheduling and time tracking in the system, it makes it convenient, makes it easy to use, makes it immediate. So you can see your open shifts, you have a dashboard working with your unstaffed schedule, you can message your caregivers, it facilitates that entire process. Certainly client care, the information is being collected in the SAN data system database. Very robust reporting, which we'll talk about, and you can manage your client information, you can manage your care plans, make instant changes that are needed, that then when the caregiver appears in the home again, They see that change to the care plan. They are reacting to it. HR and compliance, certainly in terms of tracking the compliance of your caregivers, ensuring that they've had their in-services, their training, etc., what skill sets they have, and also optional e-learning, which we'll talk about a little bit more. Electronic visit verification, absolutely, we've spoken about that on a continual basis through this presentation and ongoing. So it's not just about compliance. It's not just about capturing and verifying that the visit occurred, but it's also about that the tasks were collected, the care plan is being followed, and non-clinical data is being collected as well. The plans of care reside in the system. It makes it easy to create them, to update them, manage them, and then document that the tasks have actually been performed. And then on the billing side, it enables you to bill quickly. It's an integrated billing system, so you can bill quickly, you can bill accurately. It's got edits that flush out anomalies, particularly in relation to auth compliance, which not only just affects billing, but it affects service. Because if the auths are being complied with and the clients are getting the authorized hours that they have been approved for, that's made very clear as part of the billing process. The reporting side, very robust reporting, certainly in terms of quality related reports, in addition to all the other types of reports, but here are just some examples. So you can see here that you can ensure that clients are getting the services that they're supposed to get, that they're getting them on the schedule that was designed for them, and that all of the clients that are supposed to be on service have caregivers assigned. You can monitor your discharges by reason. You can monitor your hospitalizations, and you can see any clients that for whatever reason have not had service for a while. And then we have Care Connect, which is an application that is an enhancement to our system. And it's got shift booking that allows newly available shifts to be pushed out to all caregivers or specific caregiver groups, to be invited to accept. They can accept it right on their device, and they can go out to the case. And it also has an e-learning option where it makes it much more convenient. Caregivers don't have to come into the office now to get their in-service or to receive higher level training. So now looking at finance, I'm a finance guy, and this is where I get the most excited. So where do finance people fit into this? So you can say operations, clinical, yes, that's easy to understand. But finance people have the skill sets to analyze this data. They can relate cause and effect. They certainly know the agency management system. They've been working in it. They've been running reports. They've been looking to get the books up to date, get bills out the door, etc. So they know how to access the data that's in the system. So, and they also can use external reporting tools such as Excel and Access and other business intelligence platforms to grab this data, pull it in there. So the clinicians and the ops people are not going to have the time or the knowledge to do this. This is where the finance people come in. They have the skills for forecasting. They can do budgeting. They can do cost analysis. And they do, after being exposed to it, have an understanding of the agency processes in terms of clinical, operational, and revenue cycle. What are some examples of some things that can be measured? So, for instance, relating care plan tasks to the diagnosis. Are they consistent? Is the diagnosis driving the care plans? Looking at adverse events related to the diagnosis. So, is high blood pressure leading to adverse events within your consumer population? Does care plan task compliance drive the occurrence of adverse events, observations relative to adverse events, and then client compliance themselves are things that the clients are not doing, driving adverse events for the client. So you can identify high-risk clients, you can avoid risk, and then you can use this data for ongoing protocols such that, you know, everybody that comes in with this diagnosis absolutely has to have these particular specific care plan tasks. So the finance department now becomes part of a trilateral partnership that supports quality. Everybody's talking to everybody else. Everybody's feeding information to everybody else, gathering data, analyzing data, evaluating it, and supporting interventions both in the clinical side and in the operations side. Where does revenue cycle management fit in? This particularly excites me as a revenue cycle management guy. Certainly, an effective and efficient process affords the staff the time to focus on quality. So if the RCM department is not coming back looking for authorizations, looking for information to appeal denials and things like that, and not tying up the caregiving staff, the staff involved with giving care, in billing related processes just to get claims paid, that gives the right people the time to focus on quality. And even then, if you get efficient enough, if you're reducing your denials and you're following up and all, and getting your bills out clean, some RCM resources can then be repurposed to support client care and being moved over to the intake side, coordination, customer service. We see it on the revenue cycle outsourcing side, where we go into a client, we contract with a client to provide outsourced revenue cycle management, and they don't let the resources go. They repurpose them and move them around in the organization to support growth, to support improved client care, et cetera. And then if you're getting paid in full and you're getting paid timely, that's financial resources that you can use then to make investments in training, clinical management, technology. So our margins are thin enough in both the home care and IDD industries. If, you know, whatever money you have coming in that can be then applied to things that the agency needs to better function is a good thing. Some more areas where revenue cycle management comes to play, certainly bonus and penalty tracking. It can be a warning system. So in the process of posting your payments, spotting the bonuses, quantifying them. In the case, there are some contracts that actually have penalties for not hitting the goals in later iterations of value-based payments. So that is an early warning system that, hey, something is not working right. Our processes aren't working right. Our protocols aren't working right. Certainly identifying denials in the area of definitely authorization compliance. You know, authorizations are, you know, intelligent intelligent roadmaps to quality. And if they're not being followed, that shows up right away in denials. So that warning can be brought back into the authorization, into the organization with regard to that. Certainly revenue integrity, held billing. Is billing being held up for edits related to authorizations? You know, certainly, like I said, denials. And then all of that, revenue integrity, billing quality, efficiency, all helps when it's done right to fund effectiveness, efficiency, allowing resources to be applied elsewhere. And in addition to that, bringing in cash that can help fund investments in quality. You know, I started to mention payment posting. Certainly, it gives you insight into, are you making your bonuses? Are you not making your bonuses? You can follow up on why not. And you can determine how well the store is being minded in the departments that are driving the care. So in this environment, outsourcing RCM, your revenue cycle management, can become an investment versus a cost. It's enabling you to grow into new service lines, but also to focus on client care. So in this environment, very important for the context of what we're talking about right now. So it's funding the investments that you need to make in this process. It's freeing up resources. It's freeing up management from having to concentrate on getting paid to actually making the plans and providing the support to the organization to improve quality. It certainly improves your profile with the payers because payers are looking for agencies and providers that are well run, and revenue cycle management and not having a lot of payment issues is an indicator of that. As we discussed, profitability. If you're managing your revenue cycle process and getting paid for your for all of your billing, it supports that whole process. And then certainly financial compliance, documentation, audits, insights. It's giving you the information that you need to do that and avoiding having management being redirected into that function. So in terms of where we are, so to be successful in the value-based payment environment, it's really about leadership. Leadership has to bring the organization together, has to coordinate the organization, has to make a commitment for value-based care to be appropriately funded with resources and money, and to make the investments and the operating changes that drive that success. So that's it for the presentation. I'm glad to see we have some time for Q&A, and our SANDATA team that's on the call with us will monitor that. There are links here to be able to get more information, to schedule a call about the SANDATA software, SANDATA Revenue Cycle Management offering, and to get copies of this webinar.
Perfect. So far we have one question. Which state
Great.
do you think will be first to launch VBC? When do you think that will happen?
Okay, so New York has already launched it. So all providers in New York of all provider types have value-based care addendum to their contracts, and the process is actually moving along. So data has been gathered. I think the baseline was established in 2017, and data is gathered on an ongoing basis. And there are providers who are starting to earn bonuses. So they're slow in coming because the state it takes time to evaluate all the data, track it down to the MCO level, track it down to the provider level, and administer that. But the way that process works is MCOs get a bonus from the state relative to the MCO member population in relation to the total statewide population, and then that gets pushed down to the providers. At least that's how it works in home care. Hospitals, et cetera, probably have, I think, have different measurement criteria and all. I know I have seen a lot coming out from Pennsylvania in the last year or so. So I think Pennsylvania is big on the horizon for value-based care, and we're seeing roadmaps. So a lot of states are probably watching the early adopters, which are New York and potentially Pennsylvania. We've heard goings on in New Jersey about it. A lot of the managed care states are very involved in this.
Thank you. And that's all the questions we have today.
Okay, great. So our contact information is up here. Feel free to use the links, and we're happy to provide whatever information we can. Feel free to reach out to me directly, phil.feldman@sandata.com. Happy to answer any questions, speak with anyone. And thanks for attending, and I'm glad everybody was here, and have a great day.